I am Dr. Mrinal Kanti. I am consultant and interventional cardiologist of Kolkata. Actually, I was the past General Secretary of Cardiological Society of India. I hope you are aware that heart failure is taking an epidemic proportion in our country, especially in the Indian subcontinent. The reason being, with the advancement of economy, our people are getting much more older, and with this, various diseases are happening along with the heart failure as well. Now, what has happened? Heart failure has changed over a period of time in a great way. The definition has changed, the concept has changed, and not only that, the classification has also changed. Now, while talking about the classification, which is very, very important for all of us to know, it is defined as heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, and heart failure with mid-range ejection fraction. Now, all these have got different kinds of approaches, different mortalities, and we will have to take care of each condition in a very, very different way. So, for the concept is concerned, the heart failure is like a spectral disorder. It can start with heart failure with reduced ejection fraction, then end with heart failure with preserved ejection fraction, or vice versa. And there is a condition which is going from one direction to the other. Naturally, the management also becomes different. Now, in our day-to-day practice, we have seen that most of the cases of acute heart failure, also known as acute decompensated heart failure, where patient actually has lot of breathlessness with expectoration coming out of the oral cavity, and with tachycardia and all other manifestations of heart failure, there we are attributing it to acute decompensated heart failure. The first condition which we will have to rule out whether we are dealing with a heart failure with preserved ejection fraction or heart failure with reduced ejection fraction. Now, if the heart failure with preserved ejection fraction is there, then possibly we can deal with this kind of patient only with diuretics, which is the crux of the treatment in this scenario. If it is heart failure with reduced ejection fraction, then possibly we can not only give the diuretics, along with that there are so many other medications like ACE inhibitors, beta blockers, and also some newer drugs like ARNI, which can be incorporated according to the stages of the or classification of the heart failure, whether NYHA 1, 2, 3 or 4. Usually we do not prescribe the ARNI or beta blockers in the stage 4 stage, but definitely we can use them in stages 1, 2 and 3. Now, in the heart failure with preserved ejection fraction, there are many factors which might be precipitating the condition. Out of this, again, infection, anemia, pulmonary embolism, atrial fibrillation, hypertension, all these can contribute to the heart failure with preserved ejection fraction, which ultimately gives rise to heart failure with diastolic dysfunction. They are also known as diastolic heart failure. Now, here we have to focus not only with the diuretics, but also we have to treat the precipitating diseases. Like atrial fibrillation, we will have to treat with antiarrhythmic drugs or with the anticoagulants. Then if it is pulmonary embolism, whether it is acute or chronic or subacute, then we will have to give again anticoagulation, might be intravenous or subcutaneous form in acute setup, and in chronic setup we have to give the oral anticoagulation. Similarly, for anemia we have to give anti-anemic drugs so that we can raise the hemoglobin. Now, so for the anemia is concerned, though it may be a precipitating factor in acute decompensated heart failure with preserved ejection fraction, but there can be actually association between heart and kidney which might influence to form the anemia in heart failure, which is basically again could be heart failure with reduced ejection fraction. So, heart failure with reduced ejection fraction again can be combined with anemia because of the kidney problem. Now, there is a nexus between the coronary artery disease, heart failure and atrial fibrillation. All these are correlated. Now, if the coronary artery disease is the cause of the heart failure, and you will have to treat the coronary artery disease either by medications or by revascularization procedure, where the revascularization could be done by either PCI or percutaneous coronary interventions or by surgery, which is also known as coronary artery bypass graft surgery, CABG. So, these are some of the principles which you will have to do or chalk out to give the best benefit to the patient. Now, so for the heart failure with reduced ejection fraction is concerned, obviously you will be treating to decongestate the patient with the diuretics, but along with that you can give ACE inhibitors, you can give beta blockers, and in case of the heart failure with preserved ejection fraction, you can use the aldosterone antagonist. Again, if you are to really give much more benefit to a patient of heart failure with reduced ejection fraction, where there may not be any ischemia, we call it non-ischemic cardiomyopathy causing acute heart failure. In that background, you can try with statin, you can try with ARNI, and in fact, ARNI has become a new boon to our armamentarium against heart failure. ARNI is an agent, sacubitril valsartan is the combination, and they have actually done a paradigm shift in the management of heart failure, where we can actually reduce the mortality and we can reduce the hospitalization. And these two factors actually affect the cost, and this cost can be minimized with the ARNI treatment, that is the sacubitril valsartan combination. And after that, of course, if they fail, then we have to assess for the feasibility of CRT or cardiac resynchronization therapy, and which also can increase the longevity of a patient. So, basically in heart failure, you are to treat the cause and you are to treat the effect, and you are not only taking care of the muscles which cause the heart failure, but also you are taking the electrical dysfunction with the help of CRT, and not only that, you can add life to each patient by adding ARNI either with the CRT therapy or with the standard medical therapy that are being practiced for long time.